Okay, time to crack open the green book. We're going to talk about chapter 6 in this book. We did chapter 6 in the other book together in this unit. The main points that you have to contend with here are pretty sparse. There's only 5 or 6 of them. But first, you need to know that it is possible to educate pretty much all patients. If you can't educate the patient, you can educate their caregiver. So it is possible to educate somebody about this patient. How you do it, what it takes to get there, how much time it takes to get there, how much effort it takes, that all varies. We still know that one-on-one patient education, it's still the best. It's been documented, and we can try all kinds of other things, but it's like this class. We know that in-person classes, brick and mortar, where everybody shows up to the same class at the same time, has been shown as a more effective means of education than online education where you're sitting alone. Because you don't just learn from me, you get to learn from one another in a group. So, technology is changing and demanding that we change with it. It is not always changing for the better, though. There are patient education materials that you can make, stuff that you can find elsewhere. We'll talk about that. We've already talked about some of those things, but they vary in quality. You need to figure out which ones are best. And let's see, the group visits, that's what I already mentioned a minute ago. Newsletters can be helpful. There are a lot of hospitals in town that send out newsletters. Whatever hospital you're closest to, chances are you're on their mailing list. It may be for the whole hospital. It may be for maybe the women's center or the children's center. And it could be just for special occasions. Maybe they're having a health fair or something. That doesn't necessarily mean you actually read the newsletter. So it's hit or miss with the newsletter. They can be full of really great information, but if nobody reads it, it doesn't really matter. And in the future, we know from everything else we're doing that we're going to have to look towards technology, the internet, podcasts, things like that, to figure out new ways to educate our patients. Here are some definitions that you probably ought to know. Hint, hint, hint. Health literacy and patient-centered care. You can read about these more in your book, but health literacy has certainly increased like exponentially in the last 15 years, primarily because of the internet. But I just read an article recently about an author who's been, I guess you could say, hacking into Wikipedia. I mean, it's not really hacking when anybody can just make changes, but he had been making revenge changes to other people's Wikipedia pages. So it just goes to show that you have to tell your patients to make sure that they vet the source of their information. So it's not uncommon for patients to come in. I told you about the man with the ozone stuff, just swearing up and down it was the greatest thing he'd ever come into contact with. In fact, he couldn't tell you what it was or where it came from. So, health literacy is a double-edged sword. There's a lot of information out there, and it's super easy to access, but so much of it is actually not really information. It's just garbage. But it sounds good, so people believe it. So health literacy, it's hit or miss. It's part of your job to make sure that people are accurately health literate. Patient-centered care is the whole process of putting the patient first. It's making sure that everything you do is for their benefit. That you're not just tossing out education because it works for you. You got to find something that works for them, that's geared towards their health and things. Once the Affordable Care Act passed, one of the first things that a lot of people nationally noticed was that they suddenly got all kinds of literature from their insurance companies regarding health conditions that they've had, for years and had them well under control. People who had high blood pressure or who were diabetic suddenly were receiving information in the mail that they didn't particularly need. It actually upset a lot of people, at least a lot of people I know, because they were thinking the insurance company is just spending thousands, probably hundreds of thousands of dollars on printing these hard copies of information I don't need. But the insurance companies did that because there are some mandates within the Affordable Care Act that stipulated they had to work at patient education. And by sending out these pieces of paper, these flyers to people, they could document that they met that criteria within the Affordable Care Act. Healthy People 2020 is actually a remodel of the Healthy People 2010, and the government will be updating this every 10 years. So when 2020 passes, we'll see 2030 next. You can go to healthypeople.gov and look at the website and see where this information comes from and how it's garnered and what the objectives are. I'll post a link for that for you. But the bottom line is Health and Human Services is patching together literature and research to try to figure out how to make Americans healthier. And it's using evidence-based research to set goals and achieve those goals. A lot of those were actually built right into the Affordable Care Act. And so if you wonder where some of the requirements of the AHA came from, here it is. It's pretty interesting, and it covers all facets of the American population, American life. It's our lifestyle, our diet, exercise, medications. But education has been at the forefront of this since it was created, and I think it was 2005. So it's been around for a while, and patient education is certainly really important. Patient-centered care is what I mentioned earlier. It's patient autonomy. I've said this over and over, and it's because it really works. It makes a huge difference. There are a lot of places who really focus on this, and I mentioned before that it is written into some medical school curriculum that you learn a good bedside manner, because you can get more from your patient. You get more information from them. They're less likely to lie to you. They're more likely to be compliant with your wishes, your goals, change their diet, their exercise, whatever they need to do. They're more likely to do that if they trust their caregiver. So patient-centered education not only educates the patient and helps them become healthier and have more control over their own life, but it helps them trust their healthcare worker more, so that in the end, they're just more compliant. They're easier to deal with, much more friendly. About 12% of the healthcare centers in the U.S. that were surveyed, again, the survey was done in 2005, I believe, they admitted that at least 12% of the time they did not give full patient-centered care. That varied for a lot of different reasons. Either they said that they didn't feel like the patient was capable of understanding the information that they gave them, or capable of caring for themselves. So perhaps they were elderly or had some other kind of health issue that mentally challenged their ability to be compliant. Could have been age-related. But also, it's pretty well documented that if you live in a lower socioeconomic area, you're going to get lower quality health care, but also you're less likely to have patient-centered health care. You're more likely to walk into a doctor's office, be given, here's your prescription, just go home. And sadly, the assumption on the part of some of those healthcare workers is it doesn't do me any good to try to educate the patient because they won't follow through anyway. I'm not sure if I mentioned this story before, but I read recently about a woman who had a baby, went for her 6-week checkup, and the doctor said, okay, everything's fine, you're fine, I'll see you in 6 weeks. And she said, but I just had my baby, this was my 6-week checkup, if I'm fine, why do I have to come back in 6 weeks? He said, because you'll be pregnant again. Now, he told her that because she was African American and in a lower socioeconomic area. She was outraged, as she had every right to be, but that's an example of not patient-centered care. It was pretty rotten, and this kind of thing happens all the time. It's exceptionally prevalent. It's so prevalent that it's getting more attention worldwide, that the United States is not treating certain people of certain races and classes as well as we would have the rest of the world believe. I think that these shifts in perception in the next 5 to 10 years and pressure from the international community will probably help us clean some of our act up, because frankly, it's pretty embarrassing that that's where we are in the United States. You expect it in other countries, but you don't necessarily expect it here. What you can do to help this situation, though, is not be one of those people. You can make the choice to be one of the people who does their best to make patient-centered care a priority. When researchers delve deeper with healthcare providers who do not provide a lot of patient education to figure out why they don't, why they make that choice, there are some consistencies that they find. Sometimes the practitioner will say, oh, the research says that patient education is not effective. What the research actually says is that patient education has to be geared towards a specific patient, and that it's not a one-size-fits-all cookie-cutter approach that works. So if in fact your educator or healthcare provider, whoever, was using this cookie-cutter method, then they probably are not seeing good, high-quality results from their patient, therefore they don't buy into it. There are also people who are just inherently lazy, and they don't want to come up with a new method for each individual patient. And sometimes time is of the essence, especially in the managed care era, when doctors and PAs, basic healthcare providers, are encouraged not to spend more than 10 minutes with a patient. Volume, quantity over quality kind of situation. So those are all challenges that have to be dealt with. There are some healthcare providers, and I'm not going to suggest that any one of you are one of these people, but I will suggest that the likelihood is high you have met one of these people. They believe that if a patient questions them at any level, that it undermines their authority, and they get offended, and it makes them angry. These people they're egoists, and they have self-esteem problems. If you get upset because a patient questions you, then either you're not doing your job right and you know it, so you're feeling guilty, or you've got some other personal problems. I have been asked by patients why I'm doing something, I've been asked in very demanding ways that I could easily have taken offense to, but I generally choose not to. I will usually assume it's just their gruff personality, and maybe they don't like me, and that's fine too. But I try not to take it to heart. I guess I'm just pretty thick-skinned. I think everybody should get that way when it comes to healthcare, though, because you're dealing with sick people. They're not going to be as nice as they would under other circumstances, and it's not their fault. They don't feel well. So if you're one of the people taking it to heart when you get challenged by a patient, stop for a minute and really assess, are you truly being challenged, or is the patient just asking you in a less than polite manner? And if that's the case, it's easier to deal with. There are some educators, and I use that term loosely because clearly they're not educating, but healthcare providers, who believe that patient education takes too long, takes up too much of my time. Well, you can argue that a couple of different ways. If you educate them, they won't come back. It's like doing something right the first time so you don't have to redo it. You can half-ass it and know the patient will come back, or should get paid twice then, I suppose. Or you can do it right the first time. It takes a little bit more time, but ultimately it will free up your time later to deal with another patient. So it's all a matter of perspective, I suppose. I don't think there's anything on this slide that you haven't already heard. Increasing patient literacy certainly helps reduce medical costs down the line. It helps people not use emergency services as much. They're more likely to know where to go to the appropriate place. They're also more likely to be advocates for their own health and have better access to health care in the first place, so they don't need to go to the emergency room as a last resort. People just feel better when they're in control of their life. That's where human beings want to be. So the more autonomy you give them, the more cooperative they are, the better your relationship with them, and the healthier they become. I'll talk about each one of these things independently in just a minute, but there are different ways you can easily incorporate patient education into your practice. You can do one-on-one discussions, you can have brochures, pamphlets, handouts, that kind of thing, Group visits are an interesting concept, so I'll talk about that in a minute. And then, of course, newsletters I mentioned earlier. Now, this is by no means an exhaustive list. You can certainly add to it. But these are the things your book covers, and these are the things that are easiest to make happen. One-on-one discussions are when you really bond with your patient. You can learn a lot about the patient by what they say, but also by what they don't say, the way they respond to you. If they're frightened, if they won't make eye contact, that's important. If you begin to recognize signs that suggest someone is lying, there's a whole slew of signs you can look for there. The way they roll their eyes up and to the left, that's an indicator that someone's lying. There are several other indicators. There are people who go through whole training sessions to spot liars. I don't think you have to go that far, but there are some small things you can learn. Now, it doesn't mean you need to call them on the lie, but if you ask someone, how many cigarettes do you smoke a day, and they give you a number while rolling their eyes upward to the left, you know that they're lying to you about the number of cigarettes they smoke. So it can be handy skills if you can acquire them. You also have the option of altering on the fly how you educate your patient. So if you begin with a handout and you just want to hand it to them and leave, and it turns out as you're standing there you figure out they can't read, then you can immediately make changes and talk them through whatever you need to discuss with them. You can hear their concerns, their questions. Again, it's a real bonding experience. So on the one-on-one educational time has, for good reason, been shown to be the number one way to teach a patient. Here's a short list of effective tips for one-on-one. It goes back to autonomy and treating them like you want to be treated yourself. So the golden rule applies here. Just don't over-explain something. Explain it in a way that they understand. Don't under-explain it either. Don't embarrass them or treat them patronizingly. Most of the stuff we've already talked about, and the rest of it I think is pretty much common sense. Okay, I have been given all kinds of literature from doctors, hospitals, pharmacists that I've gotten home and looked through it and thought, clearly nobody read this before they handed it to me. I read everything they give me, but probably more for professional reasons than personal reasons, because everything I read, I get to assimilate that, and then later as a teacher, I can use that to educate students. So I read just about everything I can get my hands on. Well, I read anything I can get my hands on anyway. But I know that I'm the exception to the rule. A lot of people don't read through these things. I also know that they're usually written at a really basic 4th, 5th, 6th grade level, and they need to be. I understand from a pedagogical standpoint why they're written like that, but I know that while it does not offend me because I understand the rationale behind it, it may offend someone else if you hand them something so simplistic, because they may make the assumption that you're handing that particular paper to them because you think that they can't understand anything more complex. So if you think you've got one of those people, you can preface the discussion by saying these are cookie cutter documents that you should not take personally. There are cultural things to consider, like those photonovellas we talked about before. Those work really well for the Spanish-speaking community, or at least they appear to. Any of you who may be in that community, if you disagree or have anything to add, please let me know. But really, you just have to make sure that what you give to your patient is culturally and literally appropriate for your patient. Here's a short list of tips for choosing patient education materials. Make sure you take the patient's age and maturity level into account. Teenagers can be really fun because they'll read something if you put a lot of foul language in it. Their parents may not appreciate it, but they'll read it and they'll assimilate it. So, you're picking and choosing. Do you want the parents to be happy, or do you want the teenager to actually read the literature, grasp it, and appreciate it? It's a fine dance. Group visits are not necessarily a new concept, but they're not used in too many places. If you go to one of the high-end big hospitals, if you go to Duke or Harvard or something, you may see these more often. But the group itself is usually made up of either physicians or healthcare staff, could be respiratory therapists in a group, and it may include educators. A lot of times those educators are like, there's nurse educators, there's actually a job description for a nurse educator, and they frequently have specialized education. Sometimes they even have credentials. So you have a group of people who can help a patient. In that group, though, you may also have other patients, so who may be in a support group with that patient, and you work your visit around the wholeness of the patient. So that if you've seen the commercials for Cancer Center Treatments of America, this is the whole way that they are designed. They have a team of people, the nutritionist, the exercise people, all the different therapists, the occupational therapists, the respiratory therapists, the physicians, psychiatrists, religious people, to help with your faith. And as a group, they sort of tag team the patient, and they found that patients tend to get better because they have this holistic approach. So that's the idea behind a group visit, is a more holistic approach. Your book mentions emails and newsletters as a quick way to deliver patient education, and also updates in the status of your clinic or your practice. I would also add websites to this list. But it gives you the opportunity to send information out to your patient that they may or may not be interested in. Again, you can't really get anybody to read these. You can't prove anybody read them. Half the time you can't prove anyone received them. So you should not use this as the only method of educating patients, and you should not use this as the primary method for treating someone with a serious condition that needs to be dealt with. This is a much more casual way of educating your patient, but it's a nice way to introduce them to new technology or new therapies, or even new staff members that you might have. So for example, if you work for a doctor's office and you're the person who does the PFTs in that office, and you have a lot of patients who regularly get new PFTs every year, every 6 months, maybe it's a cystic fibrosis clinic or a COPD clinic, and you get a brand new machine and you're really excited about it, this is a nice way to tell the patients. In addition to just giving this information to the patients, they probably have friends or relatives with the same conditions, and they are likely to tell their friends and relatives, oh, this doctor's office has this new PFT machine. You should switch from one doctor to my doctor. And so it's also a way of advertising. It's a rolled up way. As you create these, having recently created a website of my own, I now realize that the font makes a difference. Where the pictures are located makes a difference. There's actually all kinds of research into website design. It's not just the physical skill of designing a website, there's psychology involved. Of course, there's psychology involved in how they set up Costco, so that when you walk through the door, it naturally funnels you to certain places. There's a lot of marketing strategy involved here, and the more of that you utilize, the more effective your newsletter or emails will be, or your website. Your book was written just a couple of years ago in 2012, and it was speculating at the time about some of this stuff, but here it is. It's already available. Some of these things that your book 2 years ago thought was the future of patient education. So it didn't take long to catch up and exceed the things on this list. But I have sat in a dentist office and watched a video about how teeth are replaced, artificial teeth are put in. So the first one, the television programming in the waiting room, is already being used. Video games are also being used in certain cases. There is a market for this, and if you have the skills to create one of these under the right circumstances, you could probably cash in and make a ton of money. So there you have it. And the last one, with computers and the internet, you have to add iPad to that list and apps, things like that. I think even 2 years ago, even in 2012, think about it, we really didn't have apps available, and nobody knew what the term app really meant unless you were a computer geek. So now they're everywhere, and there's an app for that, undoubtedly. So to wrap this up, remember that patient education is important for a number of different reasons. It will make your life easier as the healthcare provider because the patients won't come back as often. And when they do come back, they won't be as sick. They won't be as grumbly and grumpy. They'll just be healthier and friendly. So that always makes your life a little nicer. You're going to have to figure out how to use these technologies to incorporate them. As much as I would rather not use some technology, if it's there, it's the way we're moving. I had a discussion with a friend recently who said that she felt it was really important for her son to learn how to write in cursive. He's the same age as Tommy, so he's 9 years old now. But she felt like in about 20 years, the ability to write in cursive was going to be a marketable skill because children would not have learned how to do it anymore. And that technology will have taken over so much of our lives. Children won't even have to learn how to write. And it's a bit of a scary thought, and she may be overthinking it, but who knows? There might be something to that. So you should probably make sure that you can use the technology, but that you also could work the old-fashioned way. If you wind up working in a hospital and there's some big tragic event, I hope you will remember to break out the PEapa machine to ventilate your patients. And I hope that you were taught well enough to do that, because I'm afraid there are a lot of schools that are not teaching their students how to do that anymore. And in the end, it will make you more valuable. So being able to do things the old-fashioned way, it probably will be a marketable skill on some level. And of course, good patient education helps you build a good, solid relationship with your healthcare provider and patient relationship. I'll let you read this by yourself, and if we were in a room together, I would ask any of you have any questions. If you do, just send me an email.